So, good evening, ladies and gentlemen. On behalf of Sri Lanka College of Emergency Physician, it is my great pleasure to welcome you all for this exciting webinar on quality improvement project and audit proposals in emergency department. And thank you very much for taking time to join with us. And we are delighted to see such an enthusiastic participation from medical professionals, medical trainees across the country. And for those who, unfortunately, who are unable to join with us today, we will be recording this session and we will upload this video to the college website as well. So, the purpose of today's webinar is to increase the awareness and provide the guidance on developing quality improvement projects as well as the audit proposals in the emergency department in Sri Lanka. More importantly, this webinar aims to motivate and encourage our participants to take part in the upcoming Emergency Quality Quest, which will be held as a part of the annual Academic Congress 2022. The Emergency Quality Quest is an exciting initiative organized by the Sri Lanka College of Emergency Physician with a valued support by the Royal College of Emergency Medicine. Through this competition, we hope to foster a culture of continuous quality improvement and innovation, patient safety, and evidence-based practices within the emergency department in Sri Lanka. Before we begin, I would like to extend our sincere gratitude to Dr. Taj Hassan, Emergency Department Consultant, Leeds Teaching Hospital, United Kingdom, and Chair of the Global Emergency Medicine Committee, and past President of Royal College of Emergency Medicine. His vision, his encouragement, and support has been a true blessing in making this initiative possible. Before we proceed, I would also like to extend a very special note of appreciation to our very own Dr. Kaushila Tilakaratne, emergency physician, Colombo East Base Hospital. Dr. Kaushila has successfully secured a grant support from the Royal College of Emergency Medicine, which laid the foundation for the establishment of this Emergency Quality Quest. From the initial concept to planning and coordinating, her unwavering commitment of work has been instrumental in bringing this project to a reality. So thank you, Dr. Kaushila. And we are also deeply grateful for our resource person for today, Dr. David Hammond Jones, consultant in emergency medicine, Leeds Teaching Hospital, United Kingdom. Despite his very busy professional commitment, Dr. Hammond has generously volunteered his valuable time and expertise to share his knowledge and experience with us today. So we are truly privileged to have him this evening. To all the participants, if you have any questions, queries, or doubts, please feel free to drop down into the chat box, and we will collect all your questions, and we will have a discussion just after the presentation. And without any further delay, it is my honor and privilege to invite our distinguished speaker, Dr. David Hammond Jones, to deliver today's session on quality improvement projects and audit proposals in the emergency department. Over to you, sir.
Thank you very much, Chatura, and thank you, Kaushila, for inviting me to come and speak today. So just to give you a bit of background about me, my name is David Hammond Jones. I'm an EM consultant. I work in Leeds in the north of England in the UK. And I've been involved in leadership development for over a decade, and I'm our regional leadership lead for our resident doctors in emergency medicine. And I also teach on European courses for leadership, and more recently with the South Asian Collaborative and the Centec Global with Dr. Hataja Hussain, who you've already mentioned, previous college president, who I think is one of the judges on this panel as well. And it was him who, along with Kaushila, asked me to come and speak to you today. So that's what I've come to do. And in terms of quality improvement, one of my roles is I'm a regional training program director, and all of our trainees have to do quality improvement projects every year. And as part of our annual review of their competency for progression, we have to look at their QIAT tools to see what work they've done and see if we think they're adequate to progress. So we look at quite a lot of these every year. So what do I want to talk about? What is RChem-QIP? It's the National Programme for Shaping Emergency Medicine Standards, why it matters, what is a PDSA cycle, you may have heard of those, and the role of audit in quality improvement, and then a bit about the QIAT tool and a few top tips and resources. So I'll try and get through that in a reasonably brief pace. Okay, so the RChem-QIP, it's the Royal College of Emergency Medicine Quality Improvement Programme, national framework for delivering QI across the emergency departments. All resident doctors, ST1 to ST6, which is our training time in the UK, have to complete a QIAT tool every year to show what progress they've done on quality improvement. They have to be multidisciplinary, so we encourage them to be working with other people, and it needs to be patient-centered as well. And the reason we start this from so early on is because once you become consultants and you're leading and developing your departments, having that knowledge of quality improvement is really key. And there's more to emergency medicine than just the clinical roles that we learn. So there's a few national audits you can see there that you can look at. There's local QI projects. You want to look at PDSA cycle, as we mentioned, and I'll come on to that in a bit more detail. And you want to present it at local unit level. And then there's the QIAT assessment that I'll talk through, which is how you structure your presentation of your quality improvement project. So what is quality improvement? Well, it's a continuous systematic process that uses data and established methodologies to solve complex problems, optimize processes, and enhance outcomes. But there's 6 dimensions to it, and this purple box is actually pulled from one of the Royal College websites, where it's got lots of resources for our resident doctors. And it talks about being safe, avoiding injuries, you don't want it to be harmful, efficient so that you reduce waste, effective so that it works, and that it's patient-centered, which is key, and it's timely for both patients and staff, and it's equitable. So it's, close the gaps in health status between different patient groups. And they're the sorts of things you want to be thinking about when you're thinking about a quality improvement project. This is from our Royal College online e-portfolio to help our resident doctors look at their quality improvement journey. And it talks about their creating conditions, understanding the systems, developing aims, testing changes, implementing the changes, and then spread the learning of what you've done. And if you think of that path as a journey through your quality improvement, that will really help you. So why does it matter? Well, in the UK, there's 150 departments that participate in the national RChem audits. All trainees need to have completed a QIAT. And one thing that's important when you do this is to think about PDSA cycles and how regularly you want to be doing those. It's important for patient safety. It does actually improve patient journeys, and it reduces harm. NHS improvement is actually, for us, when we use it in our resident doctors, it's about them learning the tools so that when they become consultants, they can take these tools on and develop the departments of the future. For us, it is a part of that career progression, so they need to do this every year. And it's about teamwork and leadership as well. So I mentioned that we do lots of leadership development. You need to have those skills to be able to do these projects. So how can you decide on what you're going to do your projects on? Well, there are national RChem audits for you to have a look at. There are local incident reports and near misses, so where things went wrong, how can you improve them? Patient feedback and complaints, staff frustrations with current processes, so speak to your staff, and clinical guidelines like sepsis bundle compliance, any handover quality issues, triage accuracy, and then documentation completeness. Think of it in your SMART objectives. You may have heard of SMART objectives. That's specific, measurable, achievable, relevant, and time-bound. They're all really important when you think of any project. Does it match those things? And measurable is a key point. If you can't measure the data, you can't show that you've made a change. So often what people do is they spend too long in the planning phase. They think of an idea, they develop it, they might get lots and lots of data, but before they know it, it's time to show what they've done. And actually all they've done is collect data and they haven't managed to make any changes. So think quickly, what can you do that is a good project that's going to work? Look at driver diagrams, process mapping, and fishbone diagrams to help you understand what the problem is and start collecting that data. Now, you may collect that data with audits, or you can also use run charts, which I will talk about in terms of how they're useful. Once you've got that data and you decide you're going to try your project, you need to start. And don't take too long about this. You need to do the PDSA cycle, which I'll come on to as into what that is. And then once you've done that, you re-audit and you implement and you keep going round and round and round until it's right. And eventually you write up and you present your findings in a forum where people can learn about what you've done. And many of those people hopefully will know about it already, because part of it is involving the team as you go through. So the PDSA cycle: plan, do, study, act. Identify the change idea, set aims and measures, predict what will happen, and plan data collection. Once you've planned it, you do it. You run the tests, small scale, document what happens, record data observations, and note problems encountered. And then you study it, analyze data collected, compare to predictions, summarize the learning, and identify barriers. And finally, act. Adopt, adapt, or abandon. And I'll come into that in more detail. Plan the next PDSA cycle, scale up if successful, document changes made. So what is the PDSA cycle? It's a 4-stage process used for testing changes on a small scale, learning from those tests, and refining ideas before full implementation. It's a scientific approach to systematic change, and iterative and cumulative learning loops. It reduces risk, cost, and operational disruption. The model for improvement is looking at what you're trying to accomplish, the aim. How do you know that it's an improvement? What are you going to measure? And what changes can you make the change? So just going in a little bit more detail. So the plan, preparation for strategic action. The planning phase is the most critical phase. It involves stating explicit objective and outlining specific hypothesis. Formulate questions. What do you want to learn? Make predictions. What do you think will happen and why? Develop data plan. Explicitly assign who, what, where, and when. It's a really important phase, but you don't want to spend too long in this phase, otherwise you don't get started. And then do. Executing the small-scale test. Carry out the change or intervention on a limited pilot scale to insulate the broader organization from systemic risk. Run the change pilot diligently. Document obstacles, edge cases, and deviations. Begin real-time data collection and qualitative logs. And then you study. Deep data analysis. This phase separates the scientific PDSA model from primitive trial and error routines. It focuses heavily on the why behind the findings. Formally contrast empirical data against step 1 predictions. Summarize exact operational learning discovered, and examine and flag unexpected secondary consequences. And then stage 4, act. You can adopt, adapt, or abandon. Now, if it works perfectly first time, you can adopt it. Great, that's really successful. That's unlikely. Most projects do need some fine-tuning before they work really well. Another option is abandon at the bottom. If something is really risky or creating harm, you stop it. You do not want to cause harm. Hopefully, you're going to be in the middle point, the adapt, where it's working, it's showing some promise, but there might still be things that need to be changed or things you've not anticipated. And that's when you adapt it. And that's when you go into your next PDSA cycle to refine the performance. So how do you measure it? You need to think about what your outcome measure is. Does patient care actually improve? What's your process measure? Is the new process being followed? And balancing measures. Are we causing any unintended harm anywhere else? And that is something to consider, because often we don't anticipate everything that happens. On here, there's an example of a run chart, why it matters. And you can see there that there's plot on each week, looking at a particular run of data, and you can see it gradually increasing. So what is a run chart? This is an example of a run chart. Again, this is one that's pulled from the Royal College information they've got available. The two most common types of chart you might see are run charts, or you might see something called a statistical process control chart, which is a bit more complicated. So how do you design a run chart? First of all, you state the question that the run chart will answer and obtain data. Then you gather data, generally collect at least 10 to 12 data points to detect meaningful patterns. Then you create a graph with a y-axis showing the what you're changing, and the x-axis being the time in which you're changing it. And then you plot the data and you calculate a median line, which on this graph is the blue line showing the median line for a run chart between all of the different lines that you have on the initial data sample. Now, there's a few rules, statistic rules with run charts that are important to consider, and you can look these up, but I'll just run through them briefly. So rule 1 is shift. If you get 6 or more consecutive points above or below the median line, then that's known as a shift, and that means that the median's probably changed, something has happened. Or you can have a trend, which where you have 5 or more consecutive points all going up or down, and it can go over the median line. And if you get 2 points in the same place within that trend, you count that as 1 point. And that again shows that something is happening. And then you might get too many or too few runs. This is a statistical thing. If each time you go above or below the median line, that's a run. And if you have too few of them or too many, it can cause problems with statistics. And there are ways in which you can figure out whether or not that is a useful, the right amount of runs for your data. And finally, you can have astronomical data points. So on this graph, you can see a very high point and a very low point. And when you get these, you need to consider yourself whether it is actually a problem in the data collection on that occasion, or if something untoward has happened on that day that has changed the data. When you look at this graph, you can see that the orange line is what's happening, and then they've drawn another orange line that is the linear time to triage, which is slowly improving. You can also see the blue stars is when they've done interventions, where they've put something in place. And there might be times when it goes the wrong way. It might be a change of staff, a busy day, something changes that you need to consider. But this is a really useful way of documenting change and understanding whether or not your intervention is actually helping or whether or not you need to do anything different. Now, I mentioned SPC charts. I'm not going to go into those in too much detail, but it's just to show that there are some differences between them. SPC charts are a bit more complicated. You need more data points. They use the mean rather than the median, and they can control the data a little bit more, but they are more complicated. And I think for most general purposes in quality improvement projects, a run chart is perfectly sufficient unless you're really into that statistical data and you want to go that step further. Now, one thing to consider about, a few things to consider about your project is that people are people, and expecting a project to go completely smoothly is perhaps a bit naive. Sometimes you have a tame or simple problem. Sometimes it can be a wicked problem. Most problems in emergency medicine are quite wicked. There's lots of factors affecting each other, and there's lots of things you can't anticipate in terms of what will happen. Then you need to think about what you can control, you can influence, and what you can accept or adapt. There are some things that you can't change, and if you spend too much time trying to change them, you'll just get frustrated and you won't go anywhere. So think about what you can control and you can influence, and those things that you have to accept because you can't change them, you need to adapt around. And then on the top right here, we've got the diffusion innovation model. This is how change happens in groups of people. You have the innovators, and then the early adopters, the early majority, the late majority, and then the laggards. The laggards are the ones who often make the most noise, but they're the ones who are least likely to change. So don't spend your time and energy on them because they won't change until everybody else has. Concentrate on getting that majority up past the early adopters into the early majority. Once you're in the early majority, the chances are it will tip over the edge into the late majority, and finally the laggards will join. And at the bottom there, we've got the push-pull model. This is a bit about transactional versus transformational leadership. Transactional is when you just say to people, do this, and they have to do it. And that works well in an emergency situation, but less well in a quality improvement project. Transformational leadership is where you're wanting to bring people along with you and getting them to believe in the idea so that they also want to do it with you. So establishing rapport and empathy, involving and supporting, active listening, disclosing, and creating that vision, that common ground, so that people come with you rather than feeling like they've been told what to do. Okay, a bit about the difference between quality assurance versus quality improvement. Quality assurance is a systematic process designed to ensure that products or services meet established standards and regulatory requirements. It's reactive, retrospective, and focuses on defining a baseline status quo. And this is generally where we use audit. We use audit to check that things are safe. And then we have quality improvement, where it's a proactive, continuous effort to enhance processes, reduce overall variability, improve critical outcomes. It focuses deeply on innovative, adapting systems and continually exceeding baseline standards through cultural change. Now, what do they say side by side? So assurance is looking at compliance and standards versus improvement, outcomes, and innovation. The goal in assurance is error detection, and in improvement is in system enhancement. The approach, reactive versus proactive. The methods, audits versus continuous feedback loops. And the time frame, periodic and fixed, and improvement is ongoing and dynamic. But the reality is that there is synergy in it. They're better together. They're not mutually exclusive. They're complementary components of a robust, mature quality management system. Assurance is the floor that prevents us from falling, and improvement is the ladder that allows us to climb higher. They're both really important. So coming on to your writing your QIAT report, how do you do it? Well, you need to think about stating clearly what the title and the background is. Aim statement, what are you trying to achieve? What is the purpose of the project? Your methodology, what have you used in the methodology, and what have the results shown? The discussion and learning, the learning that you've taken from it, and the sustainability and the spread. You need to think about what the project is, what the process is, and what the product is, and what the proof is. Think of those 4 Ps. Make sure that it's clear problem, statement, and aim. You've talked about the methodology. You've got the data. There's a genuine reflection on the learning, and there is evidence of team engagement, sustainability, and spread. And there's a few delivery tips there for you to think about. So this is the QIAT format. Now this is based on the this is the QIAT format in terms of how the QIAT tool that we use or up until recently used, and it's I think mirrors pretty much the one that you've been given, or the one that you will have. You look at the project, analyze the problem, write a description of the problem that you found, think about the QI methods and describe them. What is the aim of the project? What are the outcomes? What measures did you choose and why? What did they show? How did you help to improve the problem? And then what did you do to work with others? Evaluation of change. What changes did you decide to do during the project? Describe the PDSA cycles. Working with others, describe your team. How did you choose to work with them? How did the team work together? How did you encourage them? How did you manage any conflict? How did you consider the team behavior? Stakeholder engagement. Think about your stakeholders. How did you prioritize them? And patient and carer involvement. People often miss this out, but it's a real key factor. And then that self-awareness on the reflection. Personal qualities. What was it about that enabled the project to improve patient care? And your learning, longitudinal learning over a period of time. And then finally, your personal development plan. How are you going to take this forward so you can carry this on to future projects? So this is how, when we look at an ARCP, we look at how we mark a QIAT tool. To pass, we give it this orange code here, where there's a project that you've led on, evidence that you've used an MDT team, you've used QI methodology, and that you've shared the results with other people. And for it to be excellent, we want to see that it's showing significant improvement, that you've presented it nationally, and that there's evidence of QI innovation and leadership, making change. Now, this is the QIAT tool, which reflects yours and what we've used in at RChem up until recently. Now, our curriculum has changed, and actually now that is the QIAT format, and this is the marking scheme. But actually, it's pretty much the same. It's just slightly rearranged. So it's the same thing that we're doing. Now, one thing that's important is stakeholder analysis. You need to think about the power interest grid. How much power does someone have, and how much interest do they have? If they have interest but no power, you need to keep them informed, keep them on board. If they have power but no interest, keep them satisfied. And obviously, if they have both, you need to manage them clearly. Set out your vision. Think of why you're doing it. Use the transformational leadership model. Pull people towards you. Get them to believe in why you're doing it. And consider those who might derail your project. They have power too. So if you're trying to make a change at triage and the nursing team are not informed about it, they may not engage because they might see it as additional work. Whereas if you get them to believe in it, then you can get them informed, you can get them to really power this through. So make sure you do involve people and think of how it might go wrong and ensure that you use those people. Also, people often overlook using patients. Patients are a really powerful tool. I would always encourage to use patient feedback in quality improvement projects. They'll come up with things that you hadn't considered, and you're much more likely to have a successful project if you involve patients in your project. So a few pitfalls and how to avoid them. Not having good enough baseline data and just starting without that, because then you can't evidence that you've shown change. Working alone. Quality improvement projects work if you use a multidisciplinary team, and they don't if you do it by yourself. Confusing audit with QI. The two work hand in hand, but they are slightly different. And if you understand the differences, you can use them both together to use audit and quality improvement. And then you've got PDSA cycles. It's really important that you use a number of PDSA cycles so that you can see the real change. And then choosing a topic too large. When we talked about SMART objectives, one of those things is that it needs to be attainable, achievable. Think about the time that you have and think about what you can achieve. Don't make it too big, otherwise you'll fail. And then for our trainees, leaving it too late. Just don't leave your project too late. Don't spend too long in the planning phase. Get cracking with it, and you'll find that once you get going, there'll be things that you hadn't anticipated, and you'll be glad that you got going. So what makes a good QIAT? Linking it to national data, multiple PDSA cycles, root cause rigor, looking at fishbone, 5 whales, process mapping, figuring out what the problem really is. Patient and staff involvement. I've mentioned this already, but it's really key. The more people you get on board, it's more work, but it means more success. And demonstrate sustainability. Once you've shown a project works, if you do a change and it works for a short period of time and then it goes back to the status quo, then you haven't succeeded. You haven't demonstrated sustainability. You need to keep going with the project until embedded change happens. And then spread and scale up the plan and link it with RChem guidance. So in summary, take home messages and resources. Start early, choose a topic early, make sure you do PDSAs, measure before you intervene, engage your team. The MDT team is so important, and present your findings with confidence. You are the expert. You're the person who's done all this work. You know it. And there's a few key resources there. So thank you for listening. That's just a picture of Leeds General Infirmary. That is where I work. And just thought I'd say that, but I'm happy to take any questions. Thank you.
Thank you very much, sir, for that excellent and insightful